thank you so much, Dr. Lee Hunter, for joining us today. It's such a pleasure to speak with you, and we're looking forward to learning about all your exciting research that you've been undertaking. So to start with, could you just tell us a little bit in your own words about your research and the work that you do?
Absolutely. So for many years, I've been fascinated with hearing in children. I originally thought I might go into speech-language pathology or a combination. I was quite interested in children who were deaf and hard of hearing and how they would learn language. And so I think my abiding interest has been in ensuring that they get good diagnostic care as early as possible. And as the years have gone on, we've realized more and more how critical that is in terms of getting access to early intervention. But I think when I was a clinical audiologist originally, I just got the most energy and enthusiasm from working with children and their families. And so I wanted to make sure that the audiologists who were working with them had the right tools, because in the 80s when we started out, we didn't have the tools we have today. And so it's been really exciting to me to be involved in helping to make those a reality for audiologists so they can provide the best care.
Yeah, being right at the forefront of all this exciting technology, it must be really exciting. And so some of your most well-known work that you've done regards sort of normative data and DPOAE testing, and also the clinical interpretation in DPOAEs. Could you tell us a bit more about how this research came about and what the motivations were for exploring that topic?
Yes, I'd love to. So I was starting an NIH grant with some colleagues, Dr. Douglas Keefe, who's well known with wideband reflectance. I was working with him and Dr. Pat Feeney. And we had started a clinical trial working with wideband reflectance and otoacoustic emissions and ABR all together to really define hearing disorders in babies and young children. So we had a longitudinal study, and we were trying to decide what parameters we should be using. And there were so many gaps in the literature. We had really wonderful work by Michael Gorga and colleagues that told us a lot about the combined use of signal-to-noise ratio and DP level. And I had long used that in older children and adults. But I became concerned when I saw that there were some children who I knew had mild hearing loss, and they would be classified as normal on their OAEs. And a lot of clinical audiologists were saying things like, oh, we don't think OAEs can really diagnose hearing loss until it's a moderate or greater hearing loss. And I thought, hold on, that just shouldn't be true, because we know that we can detect very mild hearing losses in adults, so why can't we do that in children? So we then decided as part of this study to look at OAEs from birth through about age 1.5, since that was what we were studying in these children, and then come up with normative ranges that we thought would more accurately reflect the hearing function.
Fantastic. And we will supply our viewers with a link to download those papers so they can have a look. But could you tell us a little bit about the study design, in particular what steps were involved or what steps were taken to verify hearing levels of the participants?
Yes, so we were fortunate that we were starting with the same children and following them all the way through, so we had a longitudinal study already decided. What we didn't know, though, were what our parameters should be. So what we did is we employed the OAEs as soon after newborn screening as possible. And importantly, we had children both who had passed and who referred on their newborn screening. And we followed both of them. So we didn't just bring in the kids who had referred, we brought in a large group of children who had passed their newborn screening. And then, of course, kids get otitis media, so hearing can change over time because of that. And so we tested them at around 1 month of age with a diagnostic ABR that included bone conduction. We did wideband tympanometry at every visit, and then we saw them again at 6 months and again at 9 to 12 months. And at 6 months, we repeated the OAEs and tympanometry, and then at 9 months, we did VRA testing. So we had several different age ranges at which we could look at hearing function. And so we were able to compare children who had had normal test results all the way through and look at their developmental course. And then we were able to compare that to children who had verified conductive or sensory neural hearing loss.
Fantastic. So checking up along the way, longitudinal data, fantastic. And one of the key challenges for any piece of research, investigative normative data, is to decide what to measure and at what cutoff criteria we should be using. So what parameters did you use to determine whether DPOAEs were present in the measurements you recorded?
So that is a challenge, and there aren't clear and hard levels in terms of things like the signal level and the noise floor that you can find, several different parameters when you look into the literature. But what we decided was probably the most sensible is to keep all the OAEs that had at least a +3 signal-to-noise ratio so that we could use those data. That's the reality, in the clinic, is that you don't always have the luxury of the DPs being +6 or +10 SNR, and we really wanted to look at the noise floors and how they related to the levels. And so we used the same approach that Michael Gorga had used, where we first verified that the signal level was appropriate within 3 dB at most of what was intended. And we used a traditional clinical protocol of the 2-level signal, and all of that is quite standard. And then what we did is we ensured that the signal-to-noise ratio was at least 3 dB. And then we measured SNR over time in both the children who had normal hearing status and those who had hearing loss, and then the DP levels across frequencies over time as well.
Fantastic. And obtaining a reliable DPOE recording is really crucial to achieve before we can even think about the interpretation of the results. So what should a clinician focus on to ensure that they have actually recorded a reliable measurement?
So the very most important thing is to ensure that the stimulus is stable. So I like to ensure that I'm looking at that. If possible, some of the instruments will show you that ongoing. And more, the instruments are letting you, or they're alerting you if that it detects that the stimulus has fallen down below where it should be. But if not, if you look at that afterwards and across the frequency range to ensure that it's at least within 3 dB of the intended stimulus level, and that the noise floor is adequate. And that becomes pretty obvious when you've done a few of them. You can tell, well, the child is noisy and my noise levels are creeping up higher than they should be. In adults, we like to see them at about -20 across the frequency range, 2 kilohertz and above. It'll be higher in the low frequencies because of respiration and so forth. You can't really do anything about that. But then in children, young infants and children, we like to see it at -10 or lower. Sometimes you can't achieve that, and often this is because of otitis media. And so what we'll see is that our noise floor is higher than what we would like. And so you can't absolutely rule out that a DP level is present when the noise floor is higher. So then we look at the signal-to-noise ratio to see, can we interpret this OAE level? And if we've got a positive SNR, at least 3 dB, I like to see. I don't call that normal, but that at least tells you that you've got a DP that can be measured. And then we look at the level. And I really use the level as the primary criterion.
Okay, fantastic. And so within that DPOE measurement, there's a whole range of parameters and data that a clinician is faced with when making their interpretation. You've touched on a few of them already, but for you, what are the most important elements that define whether an OAE is present or not?
Well, of course, it depends on whether you're using a screening approach or a more diagnostic approach. And so with the screening approaches, those will really be set ahead of time in terms of usually the SNR primarily. It's often SNR driven. But I really like it when the screening approaches will also consider the level, particularly with DP grams, because the level is more indicative of the underlying hearing function, the cochlear function, whereas the SNR tells you more about the recording environment, whether the person was quiet enough to get an adequate recording. But the SNR doesn't tell you as much about the underlying cochlear function. So I start with the SNR and see if that's adequate to interpret it. And then I look at the age normative values for the level, and those will change with frequency. And so the levels tend to be higher at the mid to high frequencies, and then they tail off in the very high frequencies. But I like to look at the age relative normative data, whether it's from Gorga or from our work, where you can see it at the very young ages, and we're now trying to fill in with slightly older ages with children.
Fantastic. And in your results, you divided participants into hearing loss and normally hearing groups. Mm-hmm. What differences did you find between these groups, and were there any differences within the hearing loss group depending on the nature of the loss, i.e. conductive versus sensory neural?
That's a great question, and one we were very interested in. And it turned out that the largest number of children that we had, in fact, had conductive hearing loss. Not too surprising, since it's the most common form of hearing loss in children, as contrasted with adults who more frequently have sensory neural hearing loss. So that was one question we were very interested in. And what we did find, first of all, is that the average level for children under the age of 2 is about 15 dB higher than it is for adults. So we always say that babies have small ears, but they have big OAEs. And there's a lot of reason for that. Part of it is that their cochleas are more pristine. They haven't been subjected over the years to noise and so forth. That's thought to be one reason. But there also seem to be middle ear admittance reasons. So when we compared to wideband reflectance measures, we found that actually explained a lot of the higher level that we were getting in young children compared to adults. So it has to do with the middle ear transfer function. But anyway, we should expect infants to have about a 15 dB higher OAE level compared to adults. And so that validated the fact that we really did need age-appropriate normative data.
Brilliant. And were there any unexpected or interesting elements of the results?
One thing that we confirmed, it wasn't necessarily a surprise, but we confirmed that Gorga and others were correct, that below 2 kilohertz, OAEs are not as predictive. They're not as sensitive or specific, and a lot of that has to do with the noise floor. So that has improved a bit over time with better noise control algorithms, and if you happen to have a very quiet patient, but you can't always guarantee that. So we found that starting at 2 kilohertz and above, we got the best sensitivity and specificity for detection of hearing loss. Another surprising thing is that we think of OAEs as being very frequency specific, but actually a hearing loss at any frequency within that range of 2,000 to 8,000 affected the OAEs across a wide range of frequencies. So although we can see some frequency effects, it's not as finely tuned as we might think. And so that kind of works in our favor for young children, because if there is a hearing loss at any of those frequencies, it does tend to cause a distributed decrease in the OAEs.
Okay, so across the frequencies.
Yes. Mm-hmm.
Okay, and the normative values derived from this research have been adopted by many clinics around the world for DPOAE testing in children. What do you see as the benefit or advantage of standardizing the testing across patients and across clinics?
I think the main benefit is that audiologists can have more confidence in their test results. They can look toward normative data to validate what they're getting, and they can be more assured that they're using age-appropriate standards rather than saying, oh, I've got this young infant and I'm comparing it to data that was collected across the range from 2 to 90 years, which is really what we had previously. So you can be much more specific about, treating children as children, not just young adults, that they actually are different. And I think it gives the clinician much more confidence to move forward with going ahead with diagnostic and then into intervention, so they can feel more sure about their diagnosis and give parents more clear information earlier in the game, rather than saying, well, we need to bring them back again and again and again. The other thing that I saw that I think was a big change for us in the clinic I was working in at Cincinnati Children's Hospital is that working with our clinical audiologists, we realized that we should go ahead, if there was a conductive loss, and complete the diagnostic testing. I think there used to be a tendency to send parents away if the child had an abnormal tympanogram because it was felt that you couldn't really count on those results, but they actually are real results, and they matter, and they tell you over time the pattern. And you can tell the parents, yes, there's a hearing loss. It looks like it's in the middle ear. We have a way to treat that. I can refer you to my colleague, an ENT, and we can get that resolved, but then we need to come back and find out if there's a permanent hearing loss underlying that. And so rather than just pushing them off and not having a clear diagnosis, the audiologist has more information that they can feel more confident about, and then in turn that gives the parents more information to move forward.
Absolutely, yeah. We don't want to be dismissive of those cases. Yeah, just send them away. Great. And so alongside DPOAEs, are there any other measurements that are available that you think will sit quite nicely next to DPOAEs and complement that style of testing?
Yeah, that was a nice outcome that we found that was, I guess, not entirely unexpected, but we were really gratified to see that we were using wideband absorbance, and this is in the early days, some of the very first instruments. And what we found is that combining that with the OAE measurements, we were able to see a large difference between the ears that had been verified with conductive hearing loss in the wideband absorbance measures that were within the same frequency band as the otoacoustic emissions. And it did line up nicely with tympanometry as well. It's not like tympanometry, standard tympanometry is no good. It really is. But wideband reflectance or absorbance gave us more information across that important frequency range for understanding speech, and the same frequency range where we're making OAE measurements and ABR measurements. So it allows us to really apples to apples compare middle ear to sensory and to neural, because you could have any, it's very complicated. You can have any of those types of losses. And even if there's a neural loss, that child may also have a conductive hearing loss. I found that where we've got an auditory neuropathy case, and then the OAEs are gone the next time you see them, but you find, they have a middle ear problem. So that can help explain that change over time and that complexity that plays out, when you're dealing with real patients and not just research groups.
Absolutely. Yeah. Thank you so much for taking the time to speak with us and for sharing your thoughts. It's really grateful.
Thank you.